Well, thank you very much. It's a pleasure to be speaking with you today on antiviral therapy for COVID-19. In my talk, I'm going to speak specifically about drugs that directly act on SARS-CoV-2. You'll hear later in the program about the use of corticosteroids and anti-inflammatory agents, so I'll be narrowing the focus of my talk in the current session. These are my disclosures. And particularly, I'll talk about three topics: RNA-dependent RNA polymerase inhibitors, or RDRP inhibitors, monoclonal antibodies, and other drugs. Convalescent plasma will also be covered in a separate talk later in the program. This slide shows the RDRP inhibitors that are currently in clinical trials for treatment of COVID-19. Of course, one of these that is furthest along is Remdesivir, which now has FDA approval in the United States and is approved for use in different ways in various countries around the world. And I'll spend much of my time talking about Remdesivir today. There are also several other drugs in various earlier stages of clinical trials, including molnupiravir, which is being developed by Merck, favipiravir, which is actually in phase 3 in Japan, but hasn't made as much progress elsewhere. And then AT527, which is in phase 2 trials currently and is anticipated to enter phase 3 trials soon. There's also galidesivir, which is just in early phase studies in Brazil. I won't be saying much about these other 4 drugs and because of their early stage and because not very much data has been presented publicly about them, and really focus now on Remdesivir. Remdesivir has had several different clinical trials reported over the last 6 to 8 months. And that starts with this study published in The Lancet earlier this year of a double-blind placebo-controlled trial conducted in Wuhan, in which people with COVID-19 were randomized 2-to-1 to receive Remdesivir versus placebo. The primary outcome was time to clinical improvement by day 28. Now, because of the timing of this trial, was initiated just as the epidemic was coming under control in Wuhan, the study only enrolled a little more than half of the anticipated complete enrollment, dramatically reducing the power of the study to find differences between the treatment arms. You'll notice then that there really was no significant difference in the cumulative improvement rate between the Remdesivir and control arms. And interestingly, nor was there any difference in the antiviral activity or the rate of viral clearance, either in the upper respiratory tract or the lower respiratory tract of Remdesivir as compared to control. Now, by contrast, in an uncontrolled observational study in patients who received Remdesivir under a compassionate use authorization in the United States, we see pooled data that show that there was a cumulative incidence of improvement where half the patients improved by about day 16 or 17 in this experience overall. Now that's notable because at the same time, the days to improvement for people not receiving compassionate use Remdesivir was really substantially longer. And this difference is most notable in panel B for those who were receiving invasive oxygen support, meaning mechanical ventilation. There, the median time to improvement was about 20 days, whereas in fact, I'm sorry, this is that's right, the median time to improvement was 20 days at a time when really only about 30% of people not receiving Remdesivir who had been intubated were surviving at all. But these are not randomized trial data. For that, we need to turn to the ACT-1 study, the first truly randomized trial of Remdesivir to be reported. This was a placebo-controlled double-blind trial in hospitalized adults with COVID-19 pneumonia. Participants were randomized equally to Remdesivir or placebo, and the primary endpoint was time to recovery within 28 days. And the preliminary analysis was performed after just over 600 recoveries were attained. What you can see in panel A, looking at the overall results, is that there was a statistically significant reduction in time to recovery for the Remdesivir recipients versus those in the placebo arm. And that was about a 3 to 4 day faster recovery. This was most notable in patients who were already receiving supplemental oxygen, as illustrated in panel C, but not statistically significant in those who were not receiving oxygen. By contrast, there was really no difference at all for people who were already receiving either high flow oxygen or mechanical ventilation as supportive therapy. And this is a finding that gets carried forward in several subsequent trials that I'll talk about now. In the subsequent, in a subgroup analysis for Act 1, you can see that here's the overall benefit. There was no real difference by geographic region, not much difference by ethnicity either. And then if you look by age, clearly the younger patients had a greater benefit than older patients, but there was still benefit in older patients, no difference by gender. There was some suggestion perhaps of a slight difference that people treated earlier had a better improvement than those treated later. And clearly those receiving oxygen had the biggest effect, whereas there was no benefit for those receiving mechanical ventilation. Now, the simple trial was actually two different studies, one done in severe disease and one done in people with mild to moderate disease. And these were both studies, randomized trials that were conducted by Gilead. The study in severe disease did not include a control group. It was a randomized comparison of short course or 5 days of remdesivir versus longer course or 10 days of remdesivir, as you see illustrated here. The major eligibility criteria were diagnosis of SARS-CoV-2 by PCR, presence of pulmonary infiltrates, and an oxygen requirement necessary to maintain O2 sats of 94% or less. But patients could not be receiving mechanical ventilation or ECMO. This slide summarized the principal results. Again, remember there's no control group, so we're just looking at clinical status at day 14, time to improvement, and time to recovery. And you can see that there are no differences between the groups for any of these endpoints. These data were then compared to a contemporaneous cohort of individuals at other centers not participating in the remdesivir trials to see whether there were differences in outcome. First, starting with time to recovery, or the proportion who recovered at day 14, about 3/4 of those who were in the remdesivir cohort had recovered by day 14 compared to just 60% in the non-remdesivir cohort, and that was statistically significant. Also looking at mortality by day 14, you can see that mortality in the remdesivir group was about 7.5% versus 12.5% in the non-remdesivir cohort, again, a statistically significant difference. But these were not randomized trials, and although there were attempts to control as best they could differences between these populations, still these data, while supportive, are not definitive. The study in moderate disease was a placebo-controlled trial. This simple trial was 3 arms, again, 2 arms comparing 5 days versus 10 days of remdesivir, but then including a placebo standard of care arm. This study likewise required documentation of SARS-CoV-2 by PCR, but here patients or participants entering the trial had to be able to maintain an oxygen saturation of greater than 94% on no more than 2 liters of oxygen. 600 participants were enrolled initially, and here the primary endpoint was clinical status at day 11. And the 5-day arm showed a statistically significant greater improvement compared to the standard of care. We can look at those results in more detail on this slide here. You can see that, first of all, this slide is showing the distribution by ordinal rank of various outcomes, where the best outcome is being discharged, shown in the palest color in the top of these bars, and the worst outcome is in the darkest color here, shown in black at the bottom of the bars. At day 11, the distribution of outcomes was more favorable with the 5-day remdesivir group compared to the standard of care group, and that was statistically significant, but not so for the 10-day group, which is somewhat puzzling. By day 14, however, both groups showed statistically significant differences compared to the standard of care. And then by day 28, the 10-day group, but not the 5-day group, had statistically significant benefit, although the 5-day group is trending towards significance. Now, those data have to be countered by the Solidarity study, which was a study conducted by the WHO Solidarity Trial Consortium, and which has been posted on medRxiv, but not yet peer-reviewed. This study had more general entry criteria. Participants had to be hospitalized adults with COVID-19, and they could not have received a study drug. They were randomized into different arms depending on what therapies they might or might not have already been receiving. The primary endpoint here is in-hospital mortality, whereas secondary endpoints were progression to mechanical ventilation and the duration of hospitalization. You can see that about a quarter of the participants did not require any oxygen at entry, and so would perhaps been comparable to the participants studied in the mild to moderate disease simple trial. 2/3 required oxygen at entry, and already about 10% required mechanical ventilation. This study results showed absolutely no difference in overall mortality between the control and the remdesivir groups. And this was true whether stratified by age or by participants who did or were not already requiring ventilation at the time of enrollment. In a meta-analysis that also looked at other trials data, you can see that the overall benefit of remdesivir was found to be really quite marginal and not statistically significant. This was true for both the low and high risk groups, although there's more of a suggestion of a benefit in the lower risk group not already ventilated, and was true in the Solidarity study, the ACT study, except for those requiring low flow O2, where there was clearly a benefit, and then in the Wuhan and simple trials. So these data have led to the following recommendations from the United States Department of Health and Human Services Treatment Guidelines Panel for COVID-19. For patients with mild or moderate COVID-19, they feel there's insufficient data to recommend either for or against the use of remdesivir in patients with mild and moderate COVID-19. Those who require low flow supplemental oxygen should receive remdesivir, but 5 days would be sufficient, or until hospital discharge. There's no need to keep patients in the hospital longer just to complete a course of remdesivir if they are already improving. And then for patients who require oxygen delivery through high flow devices, non-invasive ventilation or mechanical ventilation and ECMO, there's uncertainty regarding whether starting remdesivir confers a clinical benefit, and the panel cannot make a recommendation either for or against starting remdesivir. I should say that the WHO has come out with a recommendation suggesting that there are inadequate data to support the routine use of remdesivir in the treatment of COVID-19. Well, let's turn now to a discussion of monoclonal neutralizing antibodies. Human monoclonal antibodies are able to neutralize SARS-CoV-2, and they generally target the S or spike protein. These antibodies can, of course, be genetically engineered to combine multiple specificities within a single antibody by having different combinatorial domains, or by modifying the Fc receptor to extend a half-life in the same way that modifications have been introduced into broadly neutralizing antibodies for HIV. These antibodies, therefore, have potential utility for both treatment and prevention of COVID-19. The first of these antibodies to be discussed is the LYCOVI 555 antibody from Lilly, now formerly known as bamlanivimab. This antibody has been studied in the BLAZE-1 trial, which was a placebo-controlled phase 2 trial of symptomatic outpatients with COVID-19. This antibody was studied both by itself and in combination with a second antibody, LYCOVI 016. The primary endpoint in BLAZE-1 was the change in viral load endpoint at day 11, and this was met in the middle dose group, the 2,800 milligram dose group, but curiously not for the lower or higher dose groups. In addition, emergency room visits and hospitalizations were lower in the participants who received monoclonal antibody at any of the doses, just about 1.5%, compared to 6% in the placebo group, although as a secondary endpoint, these differences were not analyzed statistically in the trial. There was no study drug-related serious adverse events reported. But there were viruses with putative resistance mutations that emerged in 8 treated and 6 placebo participants. So not clear if those were being selected by antibody or even perhaps by the host's own evolving immune response. And additional trials are ongoing, although at the present time, there's no plan for bamlanivimab itself to be studied in randomized phase 3 trials or to advance to registration as a single antibody therapy. This slide shows more details from the BLAZE-1 trial, particularly of the combination studies. So first, you can see in these different shades of green, the dashed lines show the change in virus load for the low, medium, and high doses of bamlanivimab. And recall, only the middle dose achieved statistical significance at day 11. But there is clearly a reduction in all of the groups, but there's also a reduction in the control, in the placebo arm shown here. A greater reduction was found in the combination antibody arm of this study, but we don't have any data for LYCOVI 016 on its own, so we can't formally say whether this greater reduction is due to the combination per se, or might have been elicited solely by better activity of the second antibody. Looking at the change in symptom score at day 11, we see that each of the single dose, each of the antibodies, each of the dosages of the single antibody bamlanivimab was associated with a statistically significant reduction in symptom score by day 11. And that was true then, of course, of all the doses pooled. And there was a numerically greater reduction in that score for the combination, but there isn't apparently much correlation between the magnitude of virus load reduction and the symptom score change. Now, a second pair of antibodies that are being studied are those from Regeneron. These are the Regeneron COVID-2 monoclonal antibody cocktail made up of the combination of casirivimab and imdevimab, being studied in a seamless phase 1, 2, 3 trial design. To date, data have been reported on 275 outpatients who were randomized to receive either 8 grams or 8,000 milligrams or 2.4 grams of the combination antibodies versus placebo. This is the antibody combination that Donald Trump received during his hospital admission for COVID-19 a couple of months ago. What you can see is that both doses result in significantly greater reduction in the recovery of virus by swab compared to placebo. And then looking at the proportion of subjects with hospitalization or emergency room visits, we can see that in the study overall, only 4% of placebo participants required an ER visit or hospitalization, and that was reduced by half to 2%, so small numbers and modest differences. If you focus more specifically on those at high risk, this is generally people who are age 65 and older with one or more comorbidities, we can see that the hospitalization rates or ER visits were more frequent at 9%, and the incidence in the treatment arms was reduced by 2/3. So suggestion of benefit, but not definitive evidence. So numerous SARS-CoV-2 monoclonal antibodies have been produced. These mAbs reduce virus load, may protect against infection and reduce lung injury in animal models. Several human clinical trials are ongoing for treatment and now for prevention. And the preliminary data of phase 1, 2 trials of the Lilly antibody bamlanivimab and the Regeneron cocktail are encouraging, with no safety concerns to date. And both of these agents, the Lilly single antibody and the Regeneron combination antibodies, have received emergency use authorization in the United States. But phase 3 data are really needed to demonstrate clinical efficacy because the benefits demonstrated to date are really quite modest, and we really don't know if they would hold up if studied in larger populations. Let me finish just by very briefly mentioning 3 other agents. First, 2 drugs that we know for certain do not work. Hydroxychloroquine, although touted by many people as a potential antiviral agent at the outset of the pandemic, has definitively been proven in study after study to have absolutely no benefit and potentially to have some trend towards harm. Similarly, despite favorable in vitro data, there are now several clinical trials that show no benefit for lopinavir or lopinavir boosted by ritonavir, and we know that other protease inhibitors likewise show little evidence for any activity in vitro. Unknown is the potential activity of the TMPRSS2 inhibitor camostat. TMPRSS2 is a host protease that's necessary for processing the spike protein to allow virus entry. And it can be inhibited by camostat, which is a drug already approved in some countries for treatment of pancreatitis. You can see in these data from this Cell paper by Hoffman et al. That camostat is able to inhibit the entry of pseudoviruses expressing the SARS-CoV-2 spike protein, as shown here. It likewise inhibits SARS-CoV-1. But note that this inhibition is only about 50%. And that's because other proteases, other host proteases, notably cathepsin B and cathepsin L, can also process the spike protein. And it's only when both proteases, or all 3 of those proteases actually, are inhibited that you see full inhibition of virus entry. So while there are ongoing trials of camostat, most notably at the present time the Camelot trial, it's unclear to my mind whether there's really much reason to suspect a substantial clinical benefit from this drug. But as always, the clinical trials will tell. So with that, I thank you and turn this back to our moderators.